clarification to what you can give. So there were these agencies that were operating sort of in this gray zone, that were collecting finder's fees and sort of connecting egg donors with recipients. Not to say they don't exist anymore, but because of the new rules, there's a lot more restrictions on those. So by far, like most eggs either come from someone that you know and they do a fresh cycle, or frozen eggs from the USA.
All right, can you talk about surrogacy in BC? Is it legal? Where does a patient find surrogate candidates?
Yeah, so surrogacy is legal in Canada. So is, donor sperm. Both of those also fall under the Assisted Human Reproduction Act, which means that a surrogate, or what we would more properly call a gestational carrier. So the distinction there would be, I digress for just a second. A gestational carrier is carrying a baby that is not genetically related. So that would be, for example, if a woman had her uterus previously removed, or it was too dangerous for her to carry a pregnancy, then she could get someone else to carry her own egg. Now, if you're talking about a surrogate, that means that the woman carrying the pregnancy also provided the egg. Both are legal in Canada, but again, the service has to be altruistic and only receivable expenses can be reimbursed. So it's the same situation. These agencies, while they do exist, are under a lot more regulation now. So they're becoming a lot more common. Generally, it comes from an altruistic friend, acquaintance, family member.
You're quoted as saying a uterus doesn't age. Can we do IVF in post-menopausal women?
So the uterus will respond to estrogen even after menopause. So that means that if you give her exogenous estrogens, such as tablets of 17-beta estradiol or estrase, the uterine lining will grow, and you can give her exogenous progesterone, and then you can transfer an embryo, and she can carry a pregnancy. So yes, we can do frozen donor eggs or donor eggs in a woman who is after menopause. Of course, if she's in menopause, we can't do in vitro fertilization by retrieving her own eggs, because by definition, there would be virtually no eggs left at that point.
And we'll do one last one. Is there a compatibility test prior to IVF?
So not with respect to HLA matching, no. Generally, the only thing that's in that realm that would exist right now would be the egg donor bank screens for an ever increasing number of recessive genetic conditions. So those are those very, very long lists of conditions, most of which I hadn't otherwise heard of. And if the donor is known to be a carrier of one of those, then the intended father would also be tested to see if he is a carrier, in the very rare circumstance that there would be that 25% chance of getting a recessive condition from the donor egg and from the sperm, and for the offspring to be affected. But otherwise, no HLA matching test is required. Blood typing generally is not a criteria that would choose like whether a donor is compatible or not either.
All right, thank you so much. And additional questions can be put directly into that Q&A box, and we will work on getting those answered.
Perfect. All right. So I'm just going to carry on here because we're running exactly on time, which is really great. So the next speaker is Dr. Chris Wu. Chris is a urologist. He completed his medical school at the University of British Columbia and urology residency at McMaster University in Hamilton. He then did a fellowship in male reproductive medicine and andrology at the University of Toronto under Dr. Jarvie and Dr. Kirklow and Dr. Ethan Grober, with a special focus on urological microsurgery and penile reconstruction procedures. So Dr. Wu practices general, adult, and pediatric urology in Fraser Health. He's based out of Burnaby Hospital, but also works at Eagle Ridge in Port Moody and Royal Columbian Hospital in New Westminster. And his areas of interest include male infertility, andrology, and minimally invasive urologic procedures. So thank you so much for joining us, Dr. Wu. And I asked Dr. Wu today to give us an overview of male infertility for the community physician. So you can go ahead and share your screen.
Wonderful. So let's do this one. Okay. Hopefully this works. Okay, so everyone, thank you for taking the time out of your busy day to let me present a little overview on male infertility. The topic is actually quite broad, and I just wanted to touch on several aspects of the evaluation and the workup that hopefully will help you with regards to patient care. And this is sort of what, as a urologist, how my approach and what I'm thinking as I approach a male infertility patient is. So I've had the pleasure of really working with PCRM over the past 2 years since I started practice, and I have no disclosures, so let's get started. This is just an overview of my presentation. We'll start off with some definitions. So, we'll define several terms that we'll be using throughout the presentation. Infertility is defined as a failure to achieve clinical pregnancy after attempts of regular unprotected sexual intercourse for at least a period of 12 months, as per the World Health Organization. Azoospermia itself is a complete absence of sperm in the ejaculate. Aspermia is absence of seminal fluid emission upon ejaculation. And asthenozoospermia or asthenospermia is reduced sperm motility. Cryptozoospermia is when there does not appear to be any sperm in the semen sample on the neat sample, but once you actually centrifuge the semen sample into a pellet, you're able to detect the presence of very, very low sperm counts. Oligospermia is the concentration of sperm within the ejaculate that's below the normal reference range, which is below 15 million sperm per milliliter. Necrozoospermia is absence of living sperm in the ejaculate. And teratozoospermia is normal forms percentile below the reference limit. So infertility is quite common. Up to 15 couples will not be able to conceive after 1 year of unprotected intercourse. Male factor infertility is thought to be the sole cause in up to 20% of cases, and it's thought to actually contribute in another 20 to 40% of couples with infertility. So either within the general male population, it's thought that azoospermia presents in approximately 1%, but the incidence may be as high as 15% among those undergoing evaluation for infertility. So just to give an overview of spermatogenesis, this occurs in the testicle, obviously, and within the testicles, there are several different cell types. There are the Leydig cells, which are within the interstitial part of the testicle, and as well as the germ cells and the connective tissues. At puberty, there are approximately 600 million spermatogonium, which are diploid germ cells in the testicles. They undergo continual mitotic division to further diploid germ cells. These cells then further undergo meiosis and they produce haploid sperm. The testicles are actually working quite hard. They produce about 100 to 200 million sperm per day. And it's thought that over the normal reproductive lifespan, there are production of over 1 trillion sperm. Now, spermatogenesis is directed by the Y chromosome. So there are genes located along the Y chromosome that help coordinate the entire process. And roughly it takes about 70 days to develop from a spermatocyte into a sperm. Furthermore, it takes another 12 to 21 days to transport sperm from the testicles into the ejaculatory duct. So generally, there's further capacitation of the sperm as it enters the genital tract, the female genital tract, which it acquires the ability in terms of the acrosome to bind and penetrate the ovum, as well as there's added motility. Overall, we say to patients that it takes about 3 months for sperm development and transit. What I tell patients is that any changes to therapies or anything that we try, we generally have to see what the semen analysis shows about 3 months later to reflect any current changes in treatment. Converse to this is that any changes in the semen analysis that we do see may actually reflect changes in health a bit earlier on. So, spermatogenesis. So this requires the influence of both follicular stimulating hormone as well as luteinizing hormone. So as we know, LH stimulates the Leydig cells in the testicles to synthesize and secrete testosterone. FSH actually supports the action of LH through induction of LH receptors on the Leydig cells and further stimulates production of antigen-binding proteins on the Sertoli cells. This further supports spermatogenesis. So if you were to take a look at the tissues within the testicles, the level of testosterone there is actually present in up to 50 to 100 times the concentration than found in blood. So looking at the potential etiologies of male infertility, the most common cause is idiopathic. The second most common is primary gonadal disorders, in which I would lump in varicoceles, which is also a more common presenting cause of male factor infertility. Disorders of sperm transport is the third most common. So these can include post-testicular or what we call obstructive causes. And hypothalamic pituitary disorders are actually the rarest. So as you can see, there are many potential list of hypothalamic pituitary disorders that can cause pre-testicular male infertility. These would include idiopathic causes. There are also infiltrative conditions such as hemochromatosis. There are granulomatous diseases. There's mass effect from prolactin secreting pituitary tumors. It's also important to consider other things such as infections, infarction, and certain drugs can also suppress gonadotrophin release from the pituitary. Obesity has also been found to have an effect on gonadotrophin release because there is peripheral aromatization of testosterone to estrogen, which can potentially cause negative feedback of LH at the level of the pituitary. There are also the certain very, very rare diseases that we learn about in med school, such as Kallmann syndrome, which is accompanied by anosmia. It's also it's important to remember that there are also coital disorders that may be involved. So this may be the actual mechanics of sexual activity. So there are lots of patients with erectile dysfunction, with issues with ejaculation, either anejaculation, retrograde ejaculation, and other potential mechanical factors to consider, such as severe phimosis, in which the foreskin can't even open enough for ejaculate to be deposited effectively, and also body habitus limitations. I found that, especially in the infertile population, many patients have had issues with sexual function because they may be psychologically affected by the whole experience of infertility. Many patients have talked to me about the whole process of sexual activity being a lot more mechanical than an act of intimacy with their partner. So a lot of these patients they may benefit from psychosexual counseling as well. So moving on. Primary gonadal disorders. So this would include, congenital conditions such as, not being born with any testicles. There's also cryptorchidism, which is not uncommon, and there are underlying genetic abnormalities such as Y chromosome microdeletions, as well as Klinefelter syndrome. There can be acquired issues with the testicle, including trauma, torsion, infectious diseases such as mumps or chitis. You can have gonadotoxic exposure. So I see a lot of males that have had prior chemotherapy, a lot of males who used to go to the gym a lot and use anabolic steroids, patients that have been exposed to radiation therapy, and certainly, patients with varicoceles. There are also patients with surgeries that may be compromising the testicular vasculature, such as inguinal hernia repair, prior varicocele repair, and obviously there are idiopathic causes of, testicular failure. With regards to disorders of sperm transport, there are intrinsic sperm motility issues to consider. So you can have primary ciliary dyskinesia from Cartaginer syndrome. If the testicle has been, you've had some exposures to infection, inflammation, or say they've had prior vasectomy with a vasectomy reversal, your body can develop an immune response to your sperm, which can cause anti-sperm antibodies. And this can further cause agglutination and clumping of the sperm, which impairs sperm transport. There can also be intratesticular obstruction from prior infection. There can be epididymal obstruction. So there are certain conditions such as Young syndrome in which the secretions become very, very thick and the sperm cannot travel through this. Prior gonococcal or chlamydial epididymitis can also cause obstruction of the epididymal tubules. Any sort of trauma or prior surgery, such as a spermatogenesis, which is why, as urologists, if patients are of reproductive age and they have a spermatocele or a cystic swelling in their scrotum from sort of an outpouching of one of the epididymal tubules, generally I would prefer not to operate on them until they've actually finished having children. Certain, vasectomy, very common cause of vasal obstruction. There's also hernia repairs. The next two, congenital absence of the vas deferens, is something that we should touch on, because if you suspect that a patient does not have any palpable vas deferens, this can be found in patients who are cystic fibrosis carriers or even cystic fibrosis. So then if CBAVD is found, they should be screened for CFTR testing. If patients have unilateral agenesis of the vas, this is not as commonly associated with cystic fibrosis, but it can be associated with ipsilateral renal agenesis. So if a patient has unilateral absence of vas deferens, then we would generally recommend a abdominal ultrasound assess for a kidney on that side. You can also get ejaculatory duct obstruction, either acquired or congenital. So some people have a prostatic utricle cyst that can cause obstruction of the ejaculatory ducts, and same thing with ejaculatory duct cysts. So overall, evaluation of male fertility, we have several goals. We want to be able to identify and correct any reversible causes. We want to help identify early patients that will need assisted reproductive therapies of some sort. We want to be able to identify genetic abnormalities and counsel them on this. Some of these genetic abnormalities may have further medical issues that may need further medical attention, such as endocrinopathies that may be associated with certain conditions such as Klinefelter syndrome. In those whose fertility cannot be overcome by assisted reproductive therapies, we also need to be able to counsel them that they may need to consider other venues to have children, including adoption or donor sperm. So overall, the evaluation of male fertility with regards to a patient history, we want to determine whether or not this is primary or secondary infertility, meaning that we would ask the patient, have you ever gotten a prior partner pregnant before? Not whether or not their partner has been pregnant before, but have they ever gotten anyone pregnant before? And if yes, then that's secondary infertility. With regards to their fertility history, we want to know how long they've been trying for, prior evaluations and treatments. Obviously ask about the mechanics. Are they having sex often enough? Is there any underlying sexual dysfunction? We want to know about any childhood illness, mumps, cryptorchidism, developmental history. We want to know about when they went through puberty, and obviously prior surgery, systemic illnesses. Sexually transmitted infections can also cause epididymal obstruction, so that's why we want to screen them for that. And obviously any potential previous illnesses or conditions that may actually influence testicular function, such as varicoceles, torsion, orchitis, trauma. Also, environmental exposures are important, things such as radiation, chemotherapy. We want to know whether or not they've had any occupational or heat exposures, and obviously, their social history as well, including recreational drugs, tobacco, and alcohol, all which have shown to have some impairments in terms of their semen quality. Physical examination is also important, obviously a bit more challenging to do so during the time of COVID, but generally we would want to actually have a look at them and evaluate their secondary sexual characteristics, look for any things such as gynecomastia, hair distribution, height, habitus. With regards to the genital examination, we are looking at the phallus size, any congenital anomalies such as hypospadias. We want to see if there's any phimosis. Testicular size is also important to assess for, and certainly small testicles can suggest that there may be spermatogenic failure or testicular failure of some sort. We want to feel for any masses because we do know that male infertility is a risk factor for testicular cancer, and we want to know about the actual transport of the sperm. So do they have bilateral epididymis? Do they have vasa? Do they have really to assess for any masses in the prostate, any enlarged seminal vesicles? But I can tell you that overall, the chances of finding any abnormalities in rectal examination is very, very low. Further diagnostic evaluation. So scrotal ultrasound is recommended in certain guidelines, such as the European Association of Urology, but in the Canadian guidelines for the evaluation of azoospermia, it's not really recommended as a routine evaluation. But overall, I think especially during this time when telemedicine is becoming more and more utilized, especially with COVID, I think that the scrotal ultrasound can be quite a useful adjunct. From the ultrasound, we can really have a measurement of testicular size, so we know if they have small testicles or not. With regards to testis cancer, we can see if there's any underlying masses. We can also evaluate for any epididymal abnormalities such as cysts or epididymitis, which may manifest as increased epigenicity or vascularity of the epididymis. And we can also look for varicoceles. Obviously, the mainstay of our evaluation for male fertility would be semen analysis. And this is really updated. And this is from the laboratory manual for the examination processing of human semen. And all of these numbers, so we want at least a volume of 1.5 milliliters, 39 million sperm per milliliter, 39 million sperm per ejaculate, a sperm concentration of 15 sperm per milliliter. We actually look at progressive motility of about 32% and morphology of 4%. The rest of the numbers are there. And what the WHO did was they actually looked at a large population of fertile males, and they actually took the lowest 5th percentile, and that is the lower reference range of all the numbers that you see there. The lowest 5th percentile of fertile males would have these numbers. With regards to workup of male fertility, if you have a normal semen analysis, one test is usually sufficient. But if the results are abnormal, and we would recommend at least 2 semen analyses if the first one is abnormal, further urologic workup would be advised. Again, just to define, oligospermia is less than 15 million sperm per milliliter. Asthenospermia is less than 32% progressive motile sperm, and teratospermia is less than 4% normal forms. The way that I counsel patients to provide their semen samples really would be abstinence for at least 2 to 5 days prior to collection. Avoid any heat exposures during that time, such as sauna, hot tub, using a really hot laptop on your lap for prolonged periods of time. You want to collect a specimen through either masturbation, or there are certain condoms that you can use that don't have any powder or any any lubrications that could potentially impact the sperm quality. And with regards to masturbation collection, you want to ejaculate into a sterile wide-mouthed container, and you want to keep the semen at body temperature and get it to the lab within an hour of collection. The WHO actually does recommend that the semen analysis should be done about 2 or 3 months apart, and this sort of alludes back to the fact that if you had a short course of febrile infection about at a certain time, that may adversely impact your sperm quality. So you want to sort of have one like a sperm life cycle afterwards, just to make sure that that's actually a true semen analysis, not just something that had happened. Endocrinologic workup would be indicated with abnormal semen analyses, and generally I would also recommend it in patients that complain of any sexual dysfunction and fertility, such as erectile dysfunction, low libido, especially in patients with anabolic steroid use. So I mainly look at the FSH, the LH, and the testosterone, and generally the pattern based on these numbers would help point towards a potential etiology for their infertility. So if it's hypo, we would have FSH, LH, and testosterone that are all low. If it is just abnormal spermatogenesis, then we would normally see normal LH, normal testosterone, but the FSH may be normal or increased because the signal to make the sperm is sort of boosted up. If it's testicular failure overall, then you would see both FSH and LH high and a normal testosterone or low testosterone. If patients do have signs or symptoms of hypothyroidism, low energy, consider screening TSH. And patients with erectile dysfunction, low testosterone, or visual disturbances would also consider doing a prolactin. Further genetic evaluation. So karyotype is, as per the Canadian CUA guidelines for azoospermia, for Canadian guidelines for infertility, is indicated with patients with sperm counts less than 5 million sperm per milliliter. Obviously, we're looking for any structural translocations. This would be useful for genetic counseling, as this may confer increased risk of aneuploidy or abnormalities in the fetus. Obviously, we also want to look for Klinefelter syndrome and whether or not this will need further endocrine follow-up and androgen replacement therapy in the future. Y chromosome microdeletion testing. So there are deletions in several portions of the Y chromosome that have been found to cause severe oligospermia, or even more commonly azoospermia. These sections are really broken up into AZFB. What we test for is AZFA, B, and C regions. The reason for Y chromosome microdeletion testing, or I think that the main utility of this, and this is not a test that is actually covered, so the patients will have to pay out of pocket for this, is that if the patients have a complete deletion of AZFA or AZFB, the chances of finding sperm with microscopic testicular sperm retrieval or sperm extraction are pretty much minimal. If you have an AZFC deletion, then there's about a 50% chance of finding sperm with microtessi. So that is sort of where it is a bit more useful for me as an adjunct test. If the patient is azospermic, I know that I'm going to need to take them for a potential sperm retrieval. Do want to further stratify their prognosis with sperm retrieval. So, as I mentioned, AZFA or B deletion, low probability of success with sperm retrieval. Genetic counseling. So patients with an AZFC deletion do have a higher proportion of sperm that are nullosomic for sex chromosomes. So that means that there is a potential risk of Turner syndrome in their offspring. However, they have found that most babies born to fathers with Y chromosome microdeletions are phenotypically normal, because even though their chromosome complement may not be correct, this may cause decreased implantation and higher risk of spontaneous abortions in these embryos. Cystic fibrosis testing is also another useful genetic test. There is a CFTR gene on chromosome 7p, and it's most common genetic disease of Caucasians with a 4% carrier rate. This influences the formation of ejaculatory duct, the vas, the seminal vesicles, and if the patient has absence of vas on both sides, this should prompt CFTR testing. Other findings on semen analysis that we'd find with patients with potential cystic fibrosis or CFTR gene carrier are that they would have a low semen volume, they would have an acidic semen pH, so less than 7, and azoospermia. So that's when we would also consider sending these patients for CFTR testing. They may also have clinical stigmata such as recurrent chest infections, and if a patient does have CBAVD, I would recommend that we actually need to test the female partner for CF mutations as well. Transrectal ultrasonography really has a utility in patients who we suspect are obstructed. So they have a low seminal volume. They do have bilateral palpable vasa. And on ultrasound, we would find things such as midline cysts, dilated seminal vesicles, although a normal seminal vesicle size does not rule out obstruction. So it just helps us a bit with the management. The next is testicular biopsy. And testicular biopsy, we would only do in patients that are azospermic with a normal testicular size. So there is no concern, we don't think that there's testicular failure, because we need to know, is the testicle, is the sperm not present in the semen because it's either obstructed at either the intratesticular epididymal or along the vas area. And they have to have at least one palpable vas deferens and normal FSH. So essentially, the entire clinical picture looks like they should definitely have sperm in their semen, but they don't. And that's when we would go to the source, biopsy the testicle to see whether or not there's normal spermatogenesis. At the same time, as testicular biopsy, you can consider, if we do it at a fertility clinic, is that we could do concomitant cryopreservation of testicular tissue for a future IVF-XC cycle. So testicular biopsy can be done either open or percutaneous. So this is a sort of an illustration of how it looks like when it's done open. We just take some of the testicular tubules out, very small incision. If it's just purely diagnostic, I can do it at the hospital, and I use basically a true cut biopsy needle, and I just put it through the skin and just biopsy the testicular tissue, and that's sufficient to get an answer. Management, treat the underlying cause. So if there's a coital issue with erectile dysfunction, you can consider things such as PDE5 inhibitors, Cialis, Viagra, consider intracavernosal injections, assisted reproductive therapies. If there's low libido, figure out what the underlying cause is. Is it a hormonal issue, or is it something that is psychological? Can sex therapy help? If the patient does have low testosterone, consider using HCG, because exogenous testosterone will sort of shut down the feedback cycle. If the patient has elevated prolactin, people have used cabergoline to hopefully improve things. And again, the important thing is to ensure that the patients do focus on the relationship, because infertility can take a significant toll on the relationship. In non-obstructive azospermia, treat any reversible factors. So obviously, avoid heat exposures, discontinue your anabolic steroids, and generally can take anywhere from 3 months up to a year for recovery of spermatogenesis after stopping the anabolic steroids. We want to treat any underlying infections, live as healthy of a lifestyle as possible, and you want to treat any underlying endocrine abnormalities. In men with hypogonadotrophic hypogonadism, we can actually, it depends on when they acquire the condition. So if it's prepubertal, they found that pulsatile GnRH administration or else HCG coupled with human menopausal gonadotrophin administration can actually induce spermatogenesis, but it can take up to 1 or 2 years to do this. Consider testosterone replacement in patients who are not considering parenthood after all their workup, but do not use testosterone replacement for the treatment of male infertility. And I know it's been told before, but I have had patients that have had testosterone treatment because they've had low testosterone and they're still trying to actively conceive. Varicoceles. This is basically dilated veins within the pampiniform plexus of the spermatic vein. It's present in 15% of the adult male population, up to 35% of men with primary infertility. They think that the etiology is likely multifactorial, but it's more common on the left side because of the differences in drainage of the left spermatic vein versus the right. There's also incompetence of venous valves, which cause reflux of blood, and they think that this actually causes testicular hyperthermia, reflux of metabolites, and also increased hydrostatic pressure. The grading of varicoceles is here. So grade 1 is basically you're holding on to the actual spermatic cord, and it's palpable only on Valsalva. Grade 2 is you can palpate it without Valsalva, but you cannot see it. And grade 3 is easily seen through the skin. Varicoceles repair has been associated with semen parameter improvement. Varicocelectomy can reverse sperm DNA damage. And there's a Cochrane review from 2013 suggesting that treating varicoceles in men with otherwise unexplained subfertility may improve chances of pregnancy. There are a couple options. One is a microsurgical varicocelectomy, in which we actually deliver the spermatic cord, and under a microscope and using a microdoppler, we identify this testicular artery, the lymphatics, and we tie off only the veins. The other option is percutaneous embolization, in which they just put in coils or gel foam to block off the veins. Overall, there's less upfront morbidity with embolization, but there's less chance of recurrence with a microsurgical approach. And overall, the success rate with microsurgical approach is a bit higher, although the recovery rate is a bit longer. Obstructive azoospermia. Obviously, we want to bypass the obstruction. So if it's within the testicle, the only way to do it is to do sperm retrieval. Epididymal obstruction, you can either percutaneously aspirate the sperm, such as this, and you can also take some sperm tissue via TESE. If they've had a proximal vas obstruction from vasectomy, we can either do a vas reversal or we can do a vasoepididymostomy if there's a secondary epididymal blockage right here. And patency rates are generally quite good up until 10 years after your vasectomy, and beyond 15 years, the patency rate does go down significantly. And essentially, if it's a distal vas obstruction, so if you've had a vasal injury from hernia repair, generally it's sperm retrieval. Ejaculatory duct obstruction, we can actually unroof it transurethral using a loop to hopefully open up this ejaculatory duct that's blocked. Empiric treatments for male infertility, the quality of evidence for this is quite low. There is some evidence in terms of meta-analysis data that clomiphene citrate and tamoxifen may improve some sperm quality and spontaneous pregnancy rates. Gonadotrophins may be beneficial in idiopathic male factor subfertility, and antioxidants have also been associated with improvement in sperm parameters. With regards to disorders of ejaculation, couple definitions. Anejaculation is failure of semen emission in the urethra. Retrograde ejaculation is absence of antegrade ejaculation because semen passes backwards in the bladder, either because of surgery or medications. Premature ejaculation is ejaculation in which it happens too early. Many causes of anejaculation and retrograde ejaculation. So if you have anejaculation secondary to spinal cord injury, or because you've had some sort of a retroperitoneal lymph node dissection that have affected your nerves, you can actually use a pelvic nerve feedback loop and use vibrostimulation to induce ejaculation. This is electroejaculation, which needs to be done under general anesthetic, in which they actually put an electrode in the rectum, and we can stimulate ejaculation through electrical stimulation. If you have retrograde ejaculation in the absence of spinal cord injury and anatomic abnormalities such as prior prostate surgery, we can try pharmacotherapy such as Sudafed. And we can also actually retrieve sperm from post-orgasmic urine, but we do need to alkalinize the urine. If patients have premature ejaculation, consider topical lidocaine anesthetics, or else certain SSRIs can delay ejaculation, but this can also cause erectile dysfunction. Overall, 15 couples are unable to conceive. Male factor is responsible in 20% of cases and further contributes in 30 to 40%. There's many potential reversible and non-reversible causes of male factor fertility. Overall, we recommend at least 2 semen analysis prior to referral, and I would recommend that both male and female fertility workups should be performed together. Thank you.
Thank you. I'd like to ask you a couple questions if you have
Sure.
time. To revisit one that was brought up earlier and then kind of passed along until you could answer, what is the recommended time for semen analysis? We often see at Life Labs that it is more than 100 minutes since the sample was dropped off. How does that affect the results?
Yeah, I mean, ideally, we would like to get the sperm sample to the lab. I mean, they say that there may be further, there can be DNA damage, there can be decreased motility. The actual viscosity of the semen will change with time. So, generally, it's hard to say. I know that the labs can be quite swamped. If they're having a lot of issues with, abnormal semen analyses and the actual processing time is taking a long time, then one option would be to have the patients actually do it at a fertility clinic, because I know at least PCRM is quite good at getting the semen analyses done quite quickly.
And do you have any recommendations for psychosexual counseling services for men?
Yes, there's the BC Center for Sexual Medicine that you can make a referral to. They have generally been quite good. They're seen by psychiatrists there, and they're actually very thorough, and they are able to give a very good workup. A lot of my patients have really benefited from it.